Good evening, and welcome to our Getting in the Know virtual event. My name is Colleen Dietro, and I'll be your host for this presentation. Just a little bit about myself. I've been a pediatric nurse for over 30 years. I've been a pediatric nurse practitioner for about 17 years. I have been at AI DuPont Hospital for Children in Wilmington, Delaware for about 16 years, working in the orthopedic department. I work with Dr. William McKenzie in the skeletal dysplasia program, taking care of patients with all different types of skeletal dysplasia from all over the country. I am also a member of the Little People of America Medical Advisory Board. This presentation is being sponsored by BioMarin Pharmaceuticals Incorporated, and I'm being compensated for my presentation. Before we dive in, let's meet Reagan and her mom and learn about their journey to understand achondroplasia.
What's your favorite thing to play with at the house?
Gookie.
What?
Gookie.
What's that?
My Spidey's last name.
Reagan and her personality. It's big. She is definitely a celebrity at school. She had on this super cute dress the other day, and all the kids were like, Reagan, your hair, your dress, we love your outfit, it's so cute. I'm Rachel, and my daughter Reagan has achondroplasia. There's 4 of us. My husband Ryan, our twins, Riker and Reagan, they're 5.5. I think as a parent, you just kind of want all of the information, and you don't even know what questions to ask initially because you don't know what's happening, and you don't know what you don't know. So how can you know what questions to ask? By sharing our story, I hope that there's parents out there that will be able to feel a little bit more comfortable or not struggle as long as we did in finding that sense of belonging and understanding.
So we just heard Rachel talk about not knowing where to turn to ask questions, about not knowing what she didn't know. It's common for you to feel that way. Every family is in a different stage of their achondroplasia journey, and individuals have different access to resources and communities. Today, we're going to get the facts about achondroplasia, including what causes it and how bone growth is affected. The goal for you is to become even more confident in your understanding of achondroplasia and how impaired bone growth can lead to common and important complications across a lifetime. I want you to feel empowered to identify and assemble the right care team for your child. In this presentation, we'll get to know achondroplasia from different levels. You will learn what causes achondroplasia and how it affects bone growth, how to prepare for and recognize the impact of bone growth throughout development, what specialists to turn to when you need support, and what you can do to stay informed. The presentation will not provide medical advice and is not a substitute for medical care. Raise any questions you have to your healthcare team to manage any healthcare needs. And at certain points through the presentation, I will talk about how we take care of children at AI DuPont Hospital for Children. It may not be the same way other people do it, but I will make sure that I let you know that's how we do it at our facility. You will have the opportunity to participate in today's virtual event with live polls and a moderator answer questions. Please note we will only be able to address questions related to this program's content, but will not be able to answer questions about clinical trials or investigational therapies. And you can also submit your questions throughout the presentation for question and answer session at the end. Before we get too far in, I want to start by stating that children with achondroplasia can lead happy, fulfilling lives. I have a lot of friends that have achondroplasia, and they have no issues getting around. They live very happy, fulfilled lives. But by understanding achondroplasia and its complications, you will be better prepared to give your child the right support at the right time. So let's get started with an overview of achondroplasia. While achondroplasia is rare, it's one of the most common causes of short stature or dwarfism. 1 in 25,000 children are born with achondroplasia, and there are approximately 250,000 people in the world with this condition. Achondroplasia is a genetic condition caused by a change in the FGFR3 gene. There are about 80% of children with achondroplasia. The change of this FGFR3 gene occurs spontaneously, and they're born to children whose parents do not have achondroplasia. So spontaneous happens with parents that are average stature. And there's just one little blip in the chain with the FGFR3 that's the difference between us and somebody with achondroplasia. So how is this diagnosed? It's diagnosed in several different ways. It can be diagnosed prenatally based on physical features, on prenatal ultrasounds, or genetic testing. After children are born, diagnosis can be made by physical findings, radiographic findings, and or genetic testing as well. One of the most important things to know is that achondroplasia is more than just about height. And if you ask anybody with achondroplasia, they will certainly tell you that. So one of the most important implications of achondroplasia is that it impairs a primary process of bone growth that occurs in 90% of the bones in the body. That means you can see the impact of impaired bone growth in the arms, legs, and face, but also in other bones in the body, such as the spine and or base of the skull. I always like to mention to parents that if you have an average statured child and a child with achondroplasia the same age, and you sit them next to each other, they're typically the same height because there's no difference in their trunk height. It's a difference in their extremity height. So that just gives you an idea of where the difference is coming from. Because bone growth is impaired in much of the body, a person with achondroplasia can experience serious and progressive complications that are lifelong. As I mentioned earlier, children with achondroplasia can lead happy, fulfilling lives with proper planning and support. If you know what to expect, you can help your child focus on the most important thing of all, just being a kid. And that's how we treat children in our clinic. They're a child. They just happen to be a little shorter than the other kids. There are some things that they need to be careful of, but I think if you go about that, it helps the child for a lifelong, fulfilling life. You can also visit achondroplasia.com to download BioMarin's Get the Facts Guide. So understanding bone growth and achondroplasia. We'll look at this at a little different level and go and review the FGFR3 gene and how this all works. So bone growth begins before birth in utero and keeps growing until early adulthood. The primary process of endochondral bone growth, also called endochondral ossification, happens at the growth plate. And you can see on the schematic drawing to the left, that blue line is the growth plate. That is where all the work happens. And this occurs in 90% of the bones in the body. Growth plates, like I said, are where the body makes temporary cartilage and then is replaced by permanent bone, the hard bone. This process is called endochondral bone growth and happens in almost all of the bones of the body. Cartilage in the growth plate is made of cells called chondrocytes, which contain receptors that signal to control bone growth. And as you can see in the corner of the screen, FGFR3 stands for fibroblast growth factor receptor 3, and NPRB, I couldn't see, natriuretic peptide receptor B. So endochondral bone growth, again, occurs in 90% of the bones in the body. If you have questions throughout this presentation, please remember to shoot them off to the question and answer section so we can get to them at the end. So FGFR3 and NPRB are two receptors responsible for regulating bone growth. Let's look closer at how they function together in a chondrocyte without achondroplasia. So the FGFR3 receptor sends signals that tell the bones to slow down the bone growth. As you can see in the schematic drawing to the right, that's number 4. The NPRB receptor sends signals that block FGFR3 signals in order to allow the bones the opportunity to keep growing. And then CNP which is the C-type natriuretic peptide, is what turns on the NPRB receptor and is essential to bone growth. Now let's look how this process affects somebody with achondroplasia. So on the left, we have a growth plate and chondrocyte representation of somebody with achondroplasia, and on the right is someone without achondroplasia. In achondroplasia, FGFR3 sends out too many signals. It just keeps firing and firing. So in achondroplasia, a change in the structure of the FGFR3 receptor causes it to send all those extra signals to slow the bone growth down. Because the FGFR3 receptors are overactive, the signals to slow the bone growth are stronger than the NPRB signals that tell the bones to grow. So as a result, the chondrocytes have trouble lining up to form new bone, impairing the bone growth. So impaired bone growth affects nearly all bones in the body and can lead to a serious, progressive, and lifelong complications. So later in this presentation, we'll cover complications by age group to help you and your family know what to expect and to stay prepared. So we're going to break things up with a poll question. If you have any questions about the material covered, don't forget to submit them at the end. So here's our first question. So we've learned that bone growth happens in the bone's growth plates. Do you know when growth plates are fully closed? So A, 10 years old, B, 13 years old, C, 17 years old, or D, early adulthood. I'll give you a couple seconds to answer that. Looks like you're all paying attention. So it is early adulthood. And that can vary upon gender. Boys are sometimes a little bit later to close their growth plates. That's why you'll find that boys in college tend to grow a couple inches while they're away, as opposed to some of the girls have completed their growth in high school. So we'll move on. While we know children with achondroplasia can live happy, fulfilling lives, as you can clearly see from Reagan here, she's just full of spunk in life. It's important to understand the potential complications that can be caused by impaired bone growth. Let's hear from Rachel as she recounts her efforts to learn about achondroplasia and build the healthcare team that was right for her daughter.
I didn't know anything. I didn't know what achondroplasia meant. I just knew the words. I knew dwarfism, I knew achondroplasia. When we received Reagan's diagnosis, we had no idea the complexities that would be involved in her care. We didn't realize that she was going to be seeing multiple specialists for multiple things. She sees a pulmonologist. She, at the time, was seeing a cardiologist, a neurosurgeon, and an orthopedic. We added in an ear, nose, and throat specialist. So 5 doctors in the beginning. We just were not prepared for that at all. Since Reagan's been diagnosed with achondroplasia, we've had a few surgeries and a few other complications. She had the decompression surgery at 8 months old. And then at 1 year, they did ear tubes and tonsils and adenoids. And then after her initial sleep study, they determined that her sleep apnea was still pretty severe. So she sleeps with a BiPAP every night and follows up with a pulmonologist every 6 months. I wish someone had told me that we needed to be prepared for the complications, because I'm a planner, and being able to kind of see a bigger picture and know what to expect so that as those things happened, I wasn't so thrown. We had no idea what we were doing. We had no idea where to go. We struggled to find doctors, to understand the do's and don'ts, and to have a place to look and to hear other parents' experiences, I think is just so important, because it's already hard enough to discover that you're going to have a child that's different. But when you have a child that's different and is from a community that's so small that it's hard to find that community. I think it's important to know that there's other people out there. It felt like we spent so much time playing catch up along the way that when we finally got to a space where we didn't have any doctor's appointments for 6 months, we didn't know what to do with ourselves.
We've heard from one caregiver, but let's take a look at how these complications related to impaired bone growth can help you identify steps to make sure your child receives support. In this section, I'll outline complications in relation to these 4 age groups: infant, child, teenager, and adult. As we move through this information, keep in mind, though you may be working closely with one doctor, specialists in other disciplines may be needed to help manage specific complications. Some specialists follow your child throughout their life, while others may come and go as needed at different stages. And remember to reach out to achondroplasia.com to download their care team guide. Each age group, we're also going to be talking about the new guidelines that the American Academy of Pediatrics has published in 2020. They published 2020 AAP health supervision for people with achondroplasia that outlines proactive monitoring and management based on your gait complications. So it covers 3 areas: diagnosis and genetic counseling, orientation and education, medical evaluation, health assessments and referrals when necessary, anticipatory guidance, real-world advice, and safety recommendations. You want to talk to your pediatrician or other healthcare provider about reviewing documentation to see what recommendation might apply to you. I also want to mention that, your healthcare provider may have only taken care of one child with achondroplasia, and it may be your child. So this is a great document to give them. We only know what we know. So this is a great way to educate them and to educate yourself as well. And I am certain that they will be more than happy to have this information. So having key specialists in your child's care team may be helpful for the early years of development and over time. I'm going to talk a little bit about how we work at AI DuPont Hospital for Children. We work as a team together. We meet every Thursday and review images and any issues that any of our patients are having. And we're comprised of several specialties. And again, this may not be how your facility works, but medical genetics is the gatekeeper, especially for an infant with achondroplasia. That's who we go to. He's like a pediatrician that has expertise in a skeletal dysplasia. And then some of the other people that we bring into play is the neurosurgeon, and that's a doctor who has specialized focus in brain, brainstem, and spinal cord. Sleep specialists, doctors with extra training in sleep health, maybe a physician or a psychologist, depending on the referral. At our facility, it's usually the pulmonologist. And then you have the pulmonologist, the doctor that specializes in pulmonary system that regulates our breathing, including the lungs. And then you have the ENT specialist, the ear, nose, and throat, or the otolaryngologist. So let's talk a little bit about infancy. As we think about the developmental years, infancy is both an exciting and important time for families. However, it's still necessary in the first year to begin watching for serious complications that can begin. So let's go over some of these complications. Consulting the AAP guidance is very helpful and can help you recognize some of these. So the first thing we're going to talk about is pressure on the spinal cord. And in infancy, we're talking about the spinal cord where the skull meets the spine, and that area is called the foramen magnum. As I talk about this and spinal stenosis and hydrocephalus, please keep in mind that every child with achondroplasia has foramen magnum stenosis, spinal stenosis, and hydrocephalus. It just depends on the severity of it and what the symptoms are. So what are we watching for? So we're watching for foramen magnum compression. So what does it look like? It looks like pauses in breathing during sleep, choking, gagging during feeding, lips turning blue while sleeping or feeding. That sounds really scary, doesn't it? Well, it can be. And so where do you need to turn? So you can either turn to whoever the gatekeeper is, so for instance, genetics, or maybe your pediatrician. And if they have the AAP guidance, they're going to know where to send you, and they're going to send you to a neurosurgeon. And so what's the neurosurgeon going to do? They're going to assess your infant. They're going to check reflexes, going to assess does he or she need a sleep study, and any other imaging that may be done. Maybe an MRI needs to be done of the brain. So what also ties into that is some sleep apnea. So this is the pauses in the breathing during sleep, lips turning blue while sleeping. Usually at this age, sleep apnea is related to central sleep apnea. So children with achondroplasia can have obstructive sleep apnea related to tonsils and adenoids, or they can have central sleep apnea, which is coming from the brainstem related to foramen magnum compression. So you want your child either to see a pulmonologist or somebody to recommend a sleep study. So with that information and then maybe an MRI, they can put together and see what the issues are. Is it anything that needs to be taken care of surgically? So if the foramen magnum needs to be decompressed, so that's at the top, at the base of the skull, it's a matter of taking off a little piece of the bone at the back to give it some room to breathe. The other thing is hydrocephalus. And like I mentioned, everybody with achondroplasia has hydrocephalus. It just depends on the severity of it. So what you want to look for with that is bulging of the head. So every infant is born with an open anterior fontanelle, which is right about here on the head. And sometimes you can feel that pulsating. And so that's an area where you may want to check if it feels bulging, if they're extremely sleepy, irritable, poor weight gain, or marked developmental delay. So you can reach out to your neurosurgeon again. You want to make sure that your pediatrician is tracking your child's head circumference on the achondroplasia specific growth charts to keep track of it, to make sure it's tracking along appropriately or it's not jumping up really high. And again, down the bottom of this slide, you'll see that the medical geneticist may provide ongoing care and family guidance. Typically in the early couple months with achondroplasia, and the orthopedic specialist is really not needed. But I will tell you this, that at our facility, we see children every 6 months up to the age of 6, and then after that, we see them every year. So what else can happen in infancy? It's supposed to be a happy and exciting time, but some of these things sound a little scary, I know. So what to watch for? Low muscle tone. So infants with achondroplasia can be a little bit floppy, meaning you lift their arm up, it kind of falls down a little bit, but it's all within a scope. Is this normal? Is it not so normal? These are some things that need to be checked out. So weakness, floppiness, muscle spasms in the leg, any choking or gagging while feeding. Again, you want to reach out to your neurosurgeon, either to your pediatrician or to your medical geneticist. And they're going to assess the child and want to know what it's related to. It could be related to a tight foramen magnum again. So delayed developmental milestones. So the important thing with delayed developmental milestones is do not compare your child to any other child. Even people that have average stature children, they're always comparing them. And it's really not a good thing to do. So your child is a unique individual. So there are developmental tracking sheets for children with achondroplasia. So you want to see how they're tracking along. Are there delays in sitting? Communication delay may be caused by ear issues, fluid in the ear. And so you want to reach out to your pediatrician and or ENT. You want to track the milestones, keep track of them. And also get a speech evaluation before the age of 2, because if they're having hearing issues and then speech issues, the speech issues are usually related to fluid in the ears because they can't hear what's going on. The other thing is, let's not forget about just regular infant things or regular toddler things. You know, if your infant or toddler is the 4th one in line and he's not speaking, it could be because the older kids are speaking for him. So let's not forget about the regular developmental milestones as well. Also, occasionally, some people bring a pediatric endocrinologist to be a part of their achondroplasia team because they specialize in bone growth. At our facility, we really don't reach out to endocrinologists unless it's for a specific reason. And I know I'm going along quickly, so if you have questions, please put them in the question and answer box. So additionally, there are basic recommendations to keeping an infant with achondroplasia safe. So what we typically say is anything is fine as long as it's not for a prolonged period of time. Let's be reasonable and have some common sense about it. So most infants with achondroplasia have a large head. So you're going to need to support this head. You're going to need to support the neck and the full spine. You want to provide a lot of supervised tummy time, and that's putting the infant on their belly so that they're able to strengthen up their core. It is very helpful, and it'll help them strengthen up to hold their head up as well. You want to use a solid back stroller. And sometimes in the stroller, if you don't have a solid back or you have an umbrella stroller, as long as it's not for a long period of time, it's fine. I was talking to a mom this week whose child had a significant kyphosis, and we'll talk a little bit about some back issues later, but this is important in this discussion because so infants with kyphosis, so if you look at their side and they have a little bump in their spine, that's called kyphosis there. So if you're putting an infant in their car seat or in their stroller, you want to make sure that you support the back here. Provide a little bit of support, like a rolled up infant blanket. Sometimes what we'll do is take those pool noodles, cut them in half, and then sit that behind them. So that provides a little bit support so they're not all slouched over in their car seat or their stroller. You want to keep them in a rear-facing car seat as long as possible. Don't let them sit unsupported, which I think is what we talked about. And be careful about automatic swing. So this goes back to my discussion about anything is fine as long as it's not for a prolonged period of time. You wouldn't put an average stature child in automatic swing for an hour. So we wouldn't recommend doing that with your child with achondroplasia as well. I think 20 minutes is probably a good estimate. There's no data on that. It's not for a long period of time. You can also talk to your doctor for recommendations for the best type of car seats. And I just want to go back to that little girl I was talking about before. Mom reached out because she was uncomfortable in the car. So fortunately, she was coming to the hospital for something else. So I pulled our physical therapist into the mix. And so she helped her figure out how to get the car seat to fit best, put that support behind her, and that all seemed to work well. So those are some other options as well. So the other group that we're going to talk a little bit about is children. So as we said before, every child has a different journey along this, different track along this journey, and they're at a different pace. So complications like leg bowing, hearing loss, and spinal curving can lead to delay in reaching some milestones. So we're going to talk about those now with children. So what to watch for? So leg bowing or genubero. So that's the bowing in the legs, which occurs in about 40% of children with achondroplasia. So what does it look like? The outward bowing of the legs, pain, difficulty walking, and where to turn to an orthopedic surgeon. So you need to look at this you can look at it on a day-to-day basis, but what we look for when we see a child in our clinic is progression. So is the pain occurring every day? Does it impede their activities of daily living? So they're not wanting to go out and play, they're sitting inside the whole time, or does this just occur intermittently? And again, let's go back to just regular developmental issues, not issues, just developmental normal things with kids. So a lot of like 3-year-old children sometimes have a hard time expressing what their needs are. And so sometimes they just need a little attention. It may not necessarily be their legs. So you have to you have to pull out all these issues with the kids. So we look for, is it progressive? Is it debilitating? Is he taking medication for it? And what does it look like? Does the bowing of the legs, has it gotten worse over the past couple months? Are the parents concerned about it? The other thing I want to mention with children with achondroplasia, not all of them, but when some of them run, they run with their feet like this. It's called a circumduction gait, which is completely normal. Some kids will also walk on the lateral borders of their feet, and that is fine as well. So what can we do for this? So you can do several things for it. If you if it is that progressive and debilitating, we are now tethering the growth. So if there's bowing on the outside, we put little plates where that growth plate is. You remember we had talked about growth plates earlier. So we put little plates there. It holds the growth on the outside. So then they grow in the opposite way. And so they stay in place until they're straight, and then they can come out. Occasionally, depending on how early they get put in, you may find that they get put in, they get taken out, and they may get put back in again. Just depends on where they are in their age, where this is happening. If the growth plates are closed, so there's no more growth happening, significant, and the child is having issues with it, we can do a little more complicated procedure and cut the bones and straighten them out. So that's something you can discuss with the orthopedic surgeon. The other thing is, keep in mind that if your child is walking with you, say you're going to an amusement park or something like that, and they're complaining their legs are hurting, remember your short-statured child has to walk twice as fast to keep up with his average stature siblings. So just keep that in the back of your head. So delayed walking due to the way the bones grow. So walking isn't typically expected till 2.5 years of age. There's a spectrum. We've had kids walk at 1 year. So do not fret if they haven't walked by 2, but what you want to see, are they progressing in their developmental milestones? So that's one of the reasons why we see them every 6 months when they're infants, to make sure that they're meeting all those milestones. So I saw, Johnny last time we had seen him, and he was crawling. And now we see him 6 months later, he's pulling to a stand. And mom say he's teetering, holding on to the coffee table. Well, I'm pretty sure that that child will be walking next time we see him. So those are things you need to think about and not worry. As long as they're progressing and not backsliding, you're doing okay. It's rare that we recommend a physical therapist for a child with achondroplasia. Typically, they manage on their own. They're able to do their own thing. But if you're concerned and we're concerned, then we will reach out to a physical therapist. And it's important to continue to track those milestones. So delayed speech. This is most likely due to hearing loss, which we talked about before, related to the fluid in the ears. These children may need ear tubes. I mentioned a little bit about tonsillectomy and adenoidectomy. That's also another procedure that ENT might recommend depending on what's going on with your child. Usually they need a sleep study, and typically they have obstructive sleep apnea, which is the tonsils and the adenoids are large in the back of their throat, and they're having difficulty sleeping at night and breathing. So that's another specialist you would see for that ENT. This is a lot of information. So what are some of the other issues? So as I talked about earlier, the ear canals are small. Everything's a little bit smaller, so the mouth is smaller, and so you get overcrowding of the teeth. So an orthodontist is somebody else that you can pull into your healthcare team to check your child's mouth out to see if maybe they need braces. They might need some teeth removed. So that's another important person. So lumbar lordosis is most common in children with achondroplasia. So if you remember earlier, I talked about the little girl with kyphosis. So typically below the kyphosis is the lordosis, and that's the inward curve of the lower back. Sometimes we have patients that have some complaints of pain and discomfort, and we can reach out to a physical therapist. They can do some stretching of the hip flexors and may just have some overall conditioning stretching exercises for your child for that. Obesity. Obesity can occur with children with achondroplasia, but I like to tell the families from the beginning, if we start young, and even as average stature parents, if we start with a healthy diet and encourage our kids to be active, hopefully we prevent obesity. Obesity is really important in the adult achondroplasia population, because that just aggravates some of the issues that can occur at that age. So it's important if we start young, hopefully we can carry that throughout the course of their life. What it looks like weight gain, I think we all know that. And typically it occurs in the abdomen. And where to turn, if you're really struggling with this, a nutritionist or a dietitian is helpful. And you don't need somebody that specifically works with somebody that's short stature. It would be helpful. We have somebody on the LPA board that's a dietitian. You just need somebody that knows how to set up a good meal plan and help work with you on that. You also want to keep track of things on the achondroplasia growth chart. So if you're going in to see somebody every 6 months, they should go over that chart with you and make sure that your child's on the right track. So here's another poll question for us. So how do you see yourself using a resource like the 2020 AAP Health Supervision for people with achondroplasia? Would you use it to discuss with your doctor, discuss with your child, discuss with the community, personal education, or none of the above? I'll give you a couple seconds to fill that out. Okay, 57% said discuss with your doctor, which is great. This will be great information for them. And like I said, you're going to be doing your pediatrician a good service by giving them this information. So let's talk about the teenage years. So as we all know, teenage years, whether you're short-statured or average stature, can sometimes be very difficult. For the most part, people with achondroplasia have a great disposition, and they're well liked by their classmates, but sometimes things can get you down. So what to watch for? Psychosocial challenges, what it looks like, feelings of depression, anxiety, and isolation, and where to turn, a psychologist or other mental health care provider. I get asked this question sporadically throughout the year. We do not have anybody that specifically specializes in short stature in the mental health department. So I always tell families what you need to find is a good psychologist and somebody that's recommended usually by a friend or a family member. That is the best way to go. And also our hospital did a study on the psychological challenges of short-statured people, and actually it was really not that much difference from average stature adults. But review some of the social adaptations, encourage participation in social activities and support groups. I really think that the LPA is a great place for children to meet other children like themselves, and for parents too. I think you get your best information for parents. I do a lot of education on surgeries with families, and then I'll say to the families, I think you need to talk to another parent whose child's gone through the same thing, because I can tell you all the information that you want, but I think sometimes you need the true bedside information from another parent. So spinal stenosis. So this can come about in the teenage years. So what does this look like? So spinal stenosis is pressure on the spinal cord and the nerves of the spine. So if you remember a couple slides ago, we talked about the foramen magnum, which was at the skull and at the top of the spine. Well, this tightness goes all the way down the spine. So I like to explain it to parents as this. If I have my arms out like this and the spinal cord is in the middle here, and where my fingers are here, that is my back. Where you feel the spinous processes, the bumps going down your back, so that's your back. And my arms are something called the pedicles, which keeps everything intact. So in my spine, average stature spine, there is a ton of room in here. The spinal fluid is just, bathed in the spinal cord. But in achondroplasia, these arms here are short and they're compressed. So there's not much room there for the spinal cord to breathe. Everybody with achondroplasia has spinal stenosis. It just depends on the severity of it. Some unfortunately have it more severe than others. So how does this come across in somebody with achondroplasia? So, and teenage years is really important. This is where the children start to need to know about what's going on with their body. So when they come in, I ask them certain questions and I say to them, do you know why I'm asking you these questions? And they say no. And I said, well, this is what you need to know. So if it doesn't seem right, you need to let somebody know. So what does it seem like? So I'll ask the child, how far could you walk last year without getting tired or having any feelings of fatigue? Oh, I could walk a football field. All right, how are you doing now? I can only walk about 25 yards. Okay, so that's important because that tells me that there's been a change from last year. So I'll say, so what does it feel like? Do your legs feel numb and tingly when you get to the end of those 25 yards? Sometimes children don't always understand what I mean when I say that. So I'll say, does it feel like bugs crawling up your legs? And they'll be like, yeah, that's what it feels like. Say, okay, so then how do you get it to go away? Well, most people with achondroplasia will stop and will squat. So when they squat, they bend forward and then it opens up that spinal canal area so that more CSF can get in there and let it breathe. And so then all those symptoms will dissipate and they get up and walk and go about their business. So the key thing here is this progressive? Okay, so last year, walk a football field. This year can only walk 25 yards. Anything else going on? Do your legs feel weak? Do they fall out from beneath you? And then one of the later issues that can occur is difficulty controlling bladder function. So are they having any incontinence throughout the day or at night? So those are kind of some things you have to tweeze out of the situation. So if you're concerned about that, then what do you do? Well, you would need to get an MRI of the whole spine and see what's going on. Let's see how much compression there is there. The other thing to go along with that is a good clinical exam. So when your child's assessed, we're assessing to see how strong their extremities are, upper and lower extremities. We're checking their reflexes. We check their reflexes every time they come in because I want to know if there was a change from the last time that we've seen them. So we're taking that hammer and banging on their knees or banging on their ankles. And we're looking to see if they're hyperreflective, because if they're really brisk or really hyperreflective, then something is irritating the spinal cord to make that happen. So we will get an MRI, just check everything out. Sometimes we don't get an MRI. If it doesn't seem like it's been that much of a change, maybe this child's a little bit overweight. Maybe they could use a little physical therapy. So we might suggest to watch their weight and get some PT, because a strong core makes for a strong back. So those are some of the questions you can talk to your either your pediatrician or your orthopedic surgeon or your neurosurgeon about. And keep these children in the loop. I must say, it doesn't happen frequently, but it's amazing how many children don't, or young adults don't know what's going on with themselves. We've had, not in our practice, but another surgeon, a child come for surgery, 13 years old, and not know that she was having spine surgery. So I think it's important to start young, let them know what's going on with their body. We don't need to tell them everything, but little bits at a time. And I think it will be good for them throughout the years. So moving into adulthood, adults may outgrow certain complications, but mobility and pain may be challenging. They may encounter other things that they didn't encounter before. So what is one thing that may happen? So watch for heart disease. And what does this look like? High blood pressure. I also like to let people know that if you have high blood pressure, somebody with achondroplasia, make sure that they're using the right blood pressure cuff, okay? Because people with achondroplasia, their humeruses are shorter. Sometimes they're a little bit thicker. So if they're not using an appropriate cuff, you may get an inaccurate reading. If they do have true heart disease, you'd like them to reach out to a cardiologist to get this checked. And spinal stenosis. So that's what we talked about just a little bit ago with the teenage years, pressure on the spinal cord. What I didn't talk about with the spinal stenosis is, so what do we do if it's a problem? So if it's a debilitating problem If it's significant compression, then that needs to get decompressed. So you remember I talked about the spinal cord like this. So we need to take the pressure off of that. So we need not me, but the surgeon will take off the back of the spine, take off the spinous processes, some of the arms, and then it opens it up so it can breathe. That's called a laminectomy or decompression. So we will do that at the areas that are tight on the MRI. But what if your child has a kyphosis like this? If we do that, then this is not going to be good. So then that will have to get straightened out and then spinal rods put in place. Typically kids do really well after that. Again, conduct a good physical exam, do your annual reflex assessments. So day-to-day activities can be affected. Adaptations can be made throughout life. So getting around, mobility, turning doorknobs, reaching things can be accomplished with step stools, lower door levels, and lower light switches. That can all be managed quite well. Bathing and toileting can be made easier with adaptive tools such as a toilet wand. Check out the LPA's website. They have a whole section on adaptive devices. For school, this is a great opportunity to pull in your medical geneticist and or genetics counselor. Sometimes they can have a conversation either with the social worker at school or the mental health care provider or the school nurse and say some of the things that your child may need while they're at school. For instance, the younger children, when their feet can't touch the floor, they need good support underneath their feet and they need a good support behind their back. Because I just want to go back for a couple seconds when I talked about the numbness and tingling in the legs for spinal stenosis. Sometimes we have kids come in complaining of that. But then I'll ask further questions and say, so how are you sitting? When does this occur? They'll say, oh, it occurs at school. When you're sitting in your chair? Yes. And then you come to find out that they have no support under their feet and they have no support behind their back. So their feet are dangling and then there's the back of their knee is getting cut off. So you want to make sure, the circulation, you want to make sure all that's well supported. So a great opportunity to open up the conversation with people at school. Driving is possible with pedal extenders and seat boosters. I've also seen people use hand controls as well. So with the right adaptations and support, achieving independence is the goal. I have had several parents come to me with teenage drivers. I live outside the Philadelphia area, and McGee Rehab is a great facility. I'll send patients there. They do a whole driving assessment, make sure they have the right equipment that they need. So just check your area out. You may have something similar to that there. So here's our last poll. So which specialist do you work with most closely to coordinate care for your child? So the geneticist, pediatrician, ENT specialist, pediatric endocrinologist, orthopedic surgeon, pulmonologist, or somebody else. I'll give you a couple seconds to answer that. 100% geneticist. There must be a lot of my patients in the audience. That's great. But like I said earlier, this is a great opportunity for you to pull your pediatrician or your pediatric nurse practitioner into the mix here. I know at our facility, we are always open to answer questions to anybody. We get questions all the time, so take advantage. So it's important to understand how many different disciplines are involved. It takes a village. It truly does sometimes. For Rachel, it was necessary to get a handle on coordinating care for her daughter, Reagan. So just like with your own journey to understand achondroplasia, Rachel received a lot of advice and did a lot of research. So let's check back with her one last time to hear what advice she has for other parents and caregivers.
Sometimes advocating means you recognizing that you're not happy or that you're not confident and comfortable and finding someone else that makes you feel okay. You really are the expert in your child. You're the expert in what she's been doing, what they've what they're doing, how they're acting at home, what seems abnormal. And I really had to be that person to keep track and to really tell the doctors, like, no, this might be normal for that kid, but it's not normal for my kid. Find your network. So the only people that know best about caring for a child with achondroplasia are the people that are doing it or have done it. Those resources and that network, whether it be your local LPA chapter or an online group, those are the people that are going to be able to answer all your questions. And they're not going to judge any question you have, because we've all had those questions.
So Rachel talked about finding your network and advocating for your child's care, because as a caregiver, you have insight into your child that doctors simply do not have. I've been a nurse, pediatric nurse, for a long time, and I've taught nursing students for a long time too. And I always told my students that if a parent tells you there's something wrong with their child, they are 99% correct. So you should investigate what the parent has to say. Parents' intuition is typically spot on. So you can empower yourself to have important conversations with your child's healthcare team by understanding the resources available to you and getting plugged into those great communities. So now that you're in the know, what kind of steps can you take next? So you can stay in the know with BioMarin's education website, achondroplasia.com. Consider reviewing the 2020 AAP Health Supervision for People with Achondroplasia with your physicians. Register for future events like this one and receive alerts when presentation videos become available on demand. Meet patient advocacy groups and get plugged in. And watch Jackson and Reagan's full stories and see how their families build support on achondroplasia.com. Jackson's another patient with achondroplasia, and you can see his story as well. So list of some patient advocacy groups. So Little People of America that I've mentioned before, the Magic Foundation, Growing Stronger, the Chandler Project, and Human Growth Foundation. And more information and resources for living with achondroplasia can be found through these associations. So now we'll take a look at the questions that were submitted throughout the presentation. As a reminder, this section will not cover clinical therapies or investigational therapies. So let me pull up and see what we have here. So this, hold on one second. Hold on one second. So somebody asked how to potentially use the AAP recommendations when having discussion with the healthcare provider. So, I've mentioned that a couple times before, but things, for instance, like the sleep apnea is one of them. And for each age group, the anticipatory guidance is really important to share with your pediatrician. If you feel that your child's experiencing one of those complications, you can read it in the guidance book and then go over that with your pediatrician as well. This other question just came in. Is obesity more common in children with achondroplasia? While there's no data comparing children with achondroplasia with average statured children, it is common with children with achondroplasia and can occur across the abdomen. And as I discussed before, it's important to start a healthy lifestyle from the beginning so you're able to continue that through. And if you're concerned about it, reach out to your medical geneticist or your pediatrician. One of our last questions is, how do I know the healthcare provider has the expertise my child needs? As I mentioned before about intuition, I think we usually get a good gut feeling when we start to ask certain questions if our provider has the answers. If they feel a little hedgy about them, that's probably thrown up some red flags. And that's a perfect opportunity for you to get your AAP guideline and bring that to them. So you want to answer specific questions when you're trying to find the right provider. And if they're having a hard time answering them, it may be because they just don't know. Like I said, it's nobody's fault if they don't know the information. It takes a long time to learn some of these things. So I think that is our last question. So thank you for joining my presentation and taking the time to understand more about achondroplasia. This presentation will be available on demand, so keep an eye out in your email if you would like to share this presentation with others. I truly appreciate the time you've given up tonight to spend with me. My name is Colleen Dietrich, and thank you once again for getting in the know regarding achondroplasia.